Pulmonary embolism. Embolism can be from any source, e.g. tumor, air, or amniotic fluid, but this section considers only thrombotic venous thromboembolism. Etiology, Pathophysiology, and Pathology. Faircough's triad, local trauma to the vessel wall, hypercoagulability and venous stasis, causes thrombosis in the deep veins of the legs, pelvis or, more rarely, arms, which can propagate and extend proximally. The thrombus may dislodge an embolisa to the pulmonary arterial tree. This causes physical obstruction of the vasculature and release of vasoactive substances, leading to elevation of pulmonary vascular resistance, redistribution of blood flow, causing ventilation-perfusion mismatch and impairment of gas exchange, increased right ventricular afterload, causing dilatation and dysfunction of the right ventricle. Often patients have a genetic predisposition to thrombosis but require an environmental stress to elicit overt thrombus formation. Epidemiology. The incidence of venous thromboembolism is 60-70 per 100,000 population. Despite treatment, the 3-month mortality of pulmonary embolism, PE, remains high at 17.5%. The incidence of PE doubles with each 10-year increase in age. It is estimated that PE accounts for 10% of all in-hospital deaths. Risk factors. These are divided into hypercoagulable states associated with venous thrombosis and acquired conditions that may precipitate venous thrombosis. Table 41. Risk factors for PE. Hypercoagulable states. Factor V Leiden mutation. Protein C abnormalities, mutations and/or resistance. Protein S deficiency, antithrombin 3 deficiency, hyperhomocysteinemia. Antiphospholipid antibodies, including lupus anticoagulant and anticardiolipin antibodies. Acquired conditions. Surgery, trauma, and fractures. Immobilization of any cause. Obesity. Hypertension. Increasing age. Pregnancy and postpartum. Malignancy. Chronic cardiorespiratory disease. Stroke and spinal cord injury. Indwelling central venous catheter. Current, not prior, use of combined oral contraceptive pill or hormone replacement therapy, minor risk only. Clinical presentation. Common. Small and moderate-sized PE. Isolated dyspnea. Symptoms of pulmonary infarction, pleuritic pain, cough, and/or hemoptysis. Massive PE, severe dyspnea, syncope, hemodynamic collapse, and cyanosis. Symptoms of deep venous thrombosis, DVT, swelling and tenderness in calf. Uncommon. Progressive ankle edema and dyspnea, secondary pulmonary hypertension. Pyrexia of unknown origin. Atrial fibrillation, AF. NB. A young woman with isolated pleuritic chest pain and no risk factors except the oral contraceptive pill is extremely unlikely to have a PE if she has a respiratory rate of less than 20 per minute and a normal CXR. However, the risk of missing a life-threatening condition means that you should pursue the investigation unless you can make a confident alternative diagnosis. Physical signs. Common. Tachypnoea. Tachycardia. Crackles on auscultation. Pleural rub. Uncommon. Cyanosis suggests large PE. Postural hypotension in the presence of a raised JVP. Signs of raised right heart pressure. Raised JVP with prominent a wave. Pansystolic murmur of tricuspid regurgitation. Loud pulmonary valve, P2, closure sound with wide splitting of S2. Early diastolic murmur of pulmonary regurgitation. Left parasternal heave. Swollen firm calf suggestive of DVT. Investigations. Investigations must be used in conjunction with an assessment of the clinical probability of PE. Ecg changes are often nonspecific and include sinus tachycardia and anterior T-wave inversion. Ecg changes of raised right heart pressure are rare and only seen with massive PE. These include right axis deviation, S1Q3T3, new right bundle branch block, right ventricular hypertrophy and AF. Chest radiograph. This is often normal. Abnormal findings include pulmonary oligemia, raised diaphragm, small pleural effusion and segmental collapse. Arterial blood gases. Hyposemia, in larger Ps, and hypocapnia, associated with respiratory alkalosis secondary to hyperventilation, increase suspicion of PE. Normal arterial blood gases do not exclude a diagnosis of PE. Venous ultrasonography. This is used if there is clinical suspicion of a current DVT, although normal results do not exclude a PE. Echocardiography. Echocardiography identifies right ventricular pressure overload and dysfunction. In patients with non-PE-related hemodynamic collapse, it can be used to identify alternative cardiac causes for the abnormal hemodynamic state. It is useful as a quick source of information in a critically ill patient, but does not provide a diagnosis of PE. Plasma D-dimer. This test is sensitive but not specific for the presence of thrombus, i.e. it helps to exclude the diagnosis of a thrombus. Ventilation perfusion lung scan. A normal scan rules out a PE. Abnormal scans with a high probability of PE must be treated as PE. Medium or low probability scans must be interpreted in the context of the clinical scenario and may require alternative modes of imaging. Perfusion scanning alone gives comparable diagnostic yield, Fig 94. Pre-existing lung disease makes interpretation difficult. Spiral CT of the chest with contrast. Increasingly used in the diagnosis of PE, Fig 95. Clearly the imaging technique of choice when there is pre-existing pulmonary disease. Pulmonary angiography remains the gold standard investigation. However, it is an invasive test and, with the increasing availability of spiral chest CT, is only used in rare cases where diagnosis remains unclear. NB. Consider the following in the differential diagnosis of PE. Pleurisy and breathlessness. Pneumothorax. Pneumonia. Musculoskeletal pain. Rib fracture. Asthma and chronic airflow obstruction. Other causes of circulatory collapse, myocardial infarction and cardiac tamponade. Management. Emergency. General measures are required until a definitive diagnosis is reached. Maximal inspired oxygen. Analgesia, NSAIDs are often very useful. Use opiate analgesia with caution in severe pain as this may depress respiratory efforts and/or cause hypotension secondary to vasodilation. Peripheral fluids. Give intravenous loading dose of heparin followed by infusion until a diagnosis is confirmed. Monitor cardiac rhythm, pulse, BP, oxygen saturation, and respiration rate regularly. The following are often required in cases of massive PE, especially if associated with hypotension. Thrombolysis, often recombinant tissue plasminogen activator is used, but protocol is different from that used in myocardial infarction. Can be given via a peripheral vein or pulmonary artery catheter. Give colloids if hypotensive and obtain central venous access for monitoring, preferably prior to anticoagulation. Inotropes may be required if hypotension persists. Discuss case with cardiothoracic team early. Should surgical embolectomy be required because the patient does not respond to thrombolysis and colloids, and or if thrombolysis is contraindicated. Short-term analgesia. Heparin, unfractionated heparin, UFH, or low molecular weight heparin, prevents further thrombus formation and permits endogenous fibrinolysis. If using UFH, continue until INR more than 2.0. Start warfarin once adequate anticoagulation with heparin is achieved. NB. Paradoxically, warfarin without heparin may initially increase hypercoagulability. Long-term. Continue warfarin for between 6 weeks and 3 months if the risk factor is temporary and or it is the patient's first PE. Consider long-term anticoagulation for recurrent embolism and persisting risk factors such as thrombophilia. Investigate for underlying cause if unknown. Possible investigations include thrombophilia screen, ultrasound of deep veins in lower limbs and pelvis, autoimmune screen, biopsy of suspicious lymph nodes. Consider inferior vena cava, IVC, filter for recurrent PE in the presence of adequate anticoagulation or if anticoagulation is contraindicated. Complications. The most significant complication is secondary pulmonary hypertension. Prognosis. This depends on the underlying cause. In general, the prognosis is worse for larger PE. Poor prognostic indicators include right ventricular dysfunction on echocardiography, hypotension, hypoxia, significant Ecg changes associated with right heart strain. Prevention. Primary. Consider compression stockings and prophylactic heparin in hospitalist patients, especially those with trauma, the critically ill and those undergoing general and or orthopedic surgery. Discourage smoking. Encourage early mobilization postoperatively. Secondary. Thrombophilia screening to determine whether prolonged or lifelong anticoagulation is required. Discourage smoking and advise alternatives to the oral contraceptive pill. Weight loss and BP control if necessary. Consider IVC filter in selected cases.